names of Joseph. Today's topic is hemolytic disease of newborn, HDN. Hemolytic disease of newborn is also known as Erythroblastosis Fetalis, and it's a significant neonatal condition that is characterized by destruction of fetal or newborn red blood cells, which is caused by immune response incompatibilities between mother and fetus. This incompatibility will lead to anemia and bilirubin elevation, which is jaundice, and if severe, it can result in life-threatening condition such as hydrops fetalis, which is the accumulation of fluids in the one or more compartments, and it can also lead to kernicterus, which is the brain damage caused by increased bilirubin level in the brain, especially in the basal ganglia and the brainstem. As you have seen, the primary cause of HDN is immune response, where the maternal antibodies attack the fetus red blood cells that express the antigens on their which express the antigens foreign to that of the mother. The incidence of hemolytic disease of newborn is variable, of course, depending on the population and the presence of risk factors. In the general population, the rhesus incompatibilities accounts for about 0.8% of the live births. But this is significantly reduced in countries where the rhesus immunoglobulin rho gamma is now routinely given to all rhesus negative mothers. The hemolytic disease of newborn remains an important issue in neonatal medicine due to its potential for causing the severe neonatal morbidity and the mortality. Even though, as you have seen, even though its incidence has reduced in this modern era, but it's very dangerous condition because of its severe effects to the baby. In short, hemolytic disease of newborn refers to a condition in which the red blood cells of the fetus or the newborn are destroyed by mother's antibodies due to fetal antigens different from the mother's ones. So now we are going to see the cause and the mechanism for the HDN, hemolytic disease of newborn, to occur. About the mechanism, it starts from mother, where there is a development of antibodies, specifically immunoglobulin G, that cross the placenta and bind to fetal red blood cell antigens. There it triggers the hemolysis, which is the destruction of red blood cells of the baby, of course inside the fetal circulation. This will cause hemolysis and subsequent anemia and the bilirubin accumulation and the potential accumulation of the fluids to one or more compartments, which is hydrops fetalis. Erythroblastosis Fetalis. About the issue of the causes, the causes are classified into three main categories, where the first one, which is severe, is lasers incompatibility. Second is ABO incompatibility, and the other is blood group system, like Kerry, Duffy, Kiddy, and MNS antigen incompatibility. On the first point, which is the lasers incompatibility, which is the most common, there is incompatibility between mother and fetus, where the mother may have lasers negative, means lacking antigen on their red blood cell, but the fetus is having lasers positive, to mean that there is presence of antigen in his or her own red blood cell. From here, on the lasers incompatibility, you can see that during the pregnancy or childbirth, the rhesus positive blood from the fetus can enter the rhesus negative mother's circulation, triggering the immune response, where she produces antibodies against the rhesus antigen. In subsequent pregnancy of the rhesus positive fetus, these antibodies can cross the placenta and attack the fetal red blood cells, causing hemolysis, which is the destruction of red blood cells of the fetus. On the ABO incompatibility, ABO incompatibility occurs when the mother's blood group O, the mother's blood group is O, and the fetus blood group is A or B or AB, with the lesser severe than incompatibility. This can lead to hemolysis, and if the maternal antibodies anti-A or anti-B cross the placenta and attack the fetus red blood cells. On the third one, apart from rhesus and the ABO incompatibilities, there are other blood group systems like Kerry, Duffy, Kid, and MNS, which can cause hemolytic disease of newborn. For example, for Kerry, if the Kerry negative mother carries Kerry positive fetus, she can develop anti-Kerry antibodies. The same story to Duffy negative mother who can carry a Duffy positive baby. It can also cause hemolytic disease of a newborn. And unlike the lasers incompatibility, the Kerry antibodies not only destroy the fetal blood cells but also suppress the fetal ribs production, to mean that Kerry blood groups system is having the capability to inhibit the erythropoiesis in the fetal in the fetus. About the clinical features of hemolytic disease of newborn, you can see the fetal anemia. From here, this anemia, of course, from hemolysis of red blood cells, which can also lead to Erythroblastosis Fetalis, especially in severe cases. And within 24 hours of birth, the baby can develop jaundice, which is the accumulation of bilirubin levels in the blood. And this accumulation of jaundice can increase where they can reach on the level of causing a brain damage due to the accumulation of bilirubin in the brain, specifically in the basal ganglia and the brainstem. It can also cause hepatosplenomegaly, of course, due to increased extramedullary hematopoiesis from the bone. It can also cause heart failure and edema, most seen in severe anemia, of course, for those with Erythroblastosis Fetalis. About the diagnosis, uh, you have a prenatal diagnosis and the postnatal diagnosis. Uh, with the indirect comp test, you can detect the maternal antibodies. The maternal antibodies uh, by typing the blood type results and antibody screening. Other one, you can do middle cerebral artery Doppler ultrasound, which is MCA Doppler ultrasound, to assess the fetal anemia. There you can detect the fetal anemia. After birth, you can do direct comp test, where you take a cord, the blood from the cord, and you test it for antibody coated red blood cells. You can monitor also. You can also request bilirubin level, so that to monitor the risk of connecticus. You can also do a peripheral smear. A peripheral smear to show polychromasia and nucleated red blood cells. About the treatment, you can treat it before birth by performing intrauterine transfusion. And if severe anemia is detected, which is now currently, which has been done here in Rwanda, specifically at Sehashika, where they performed intrauterine transfusion. Here, the early delivery is of paramount if there is development of Erythroblastosis Fetalis. After birth, you can do phototherapy of the babies, which is able to convert the bilirubin to non-toxic form. Other one, you can do intravenous immunoglobulin to reduce the hemolysis. Other thing you can do exchange transfusion, where in severe anemia and the hyperbilinemia is very positive and give good prognosis. In prevention, you can give rhesus D immunoglobulin, which is zero gamma, where it is given within 24, given at 28 weeks of gestation and within 73 hours postpartum, and also after miscarriage, amniocentesis or trauma, they can also be given. Here you can do the proper other thing to prevent this to occur. It's the proper blood typing and matching. For example, when there is a need of blood transfusion for the pregnant women. About the complications, there is a severe anemia which can lead to Erythroplastosis Fetalis or stillbirth. Other one which is severe, it's a brain damage connecticularis caused by accumulation of bilirubin in the brain. There is uh, delayed anemia that can be caused by persistent hemolysis. Um, as a take-home message, hemolytic disease of newborn is serious but preventable condition. In each screening, rhesus, immunoglobulin administration, and appropriate prenatal and postnatal management like phototherapy and exchange transfusion are life-saving, and this will significantly reduce morbidity and mortality in and the severe cases. This may require intrauterine transfusion.